Hello, good morning. My name is Marek Trněný and I work as the head of the Department of Hematology in Charles University General Hospital. I would like just to discuss with you the case of the follicular lymphoma and the importance of the watch and wait and the place of watch and wait approach to these patients. Actually, this case started in the 2009. The lady, at that time a researcher in our university lab, she noticed the resistance in left subclavicular area in the spring 2009. The resistance was stable for a couple of months, but then subsequently it progressed and the biopsy was performed in December 2009 and the diagnosis of the follicular lymphoma grade 1-2 was performed. And on the slide you can see the BCL2 positivity, CD10 positivity and CD20 positivity. From the December 2009 till April next year, it means within 4 months, there were progression in several sites of the lymph nodes, and the patient was referred to our department. We performed the workup, and you can see that we noticed enlarged lymph nodes in different areas, and in majority of them the size of the lymph nodes was greater than 3 centimeters in the diameter. We found the bone marrow involved, we found elevated LDH, and finally we conclude the stage 4A for this patient. Actually, the question of each patient and each physician is what is the prognosis of the patient? And we use the FLIPI prognostic score published in 2004 and updated by the FLIPI2 a couple of years ago. And this score used the age, clinical stage, number of the nodal site, LDH and the hemoglobin level to predict or to prognose the outcome of the patient. And based on these parameters, the prognosis was in the category of the high risk. The question is if the FLIPI itself is sufficient for starting of the treatment. So if we should treat the patient based on the high-risk FLIPI. Actually, we do not use the FLIPI for the starting of the treatment, but we use GELF criteria. It means we try to define the tumor burden of the patient, and the GELF criteria are based on the bulky disease, the number of the enlarged lymph nodes greater than 3 centimeters on the diameter, the presence of the cytopenia, involvement of the extranodal sites greater than 7 centimeters, etc. By the definition, this patient was a bit borderline. So we found that in the majority of sites there was a diameter was slightly higher, above the 3 centimeters. So what approach do we have for the low burden tumor patient, and what approach do we have for high tumor burden of the patients? If the patients would be low burden, it means that I think that we can offer the patient to watch and wait. We have a couple of trials. They compared the immediately started treatment versus observation. One is more than 10 years ago published paper in the Lancet when UK researchers compared the chlorambucil monotherapy versus observation and the delay onset. And as you can see, at 10 years, 20% of patients were chemotherapy-free. And moreover, there was no difference in the outcome of the patients regardless they received the treatment at the beginning or if they wait for the further progression. But what about in the rituximab era? Early in the last decade, some papers appeared that the rituximab monotherapy can prolong the necessity of other treatment. It means can prolong the progression-free survival. So finally, the randomized trial was performed again by the UK group, and just recently the data have been published, and you can see that there is a significantly prolongation of the progression-free survival in the rituximab-treated patient, but on the other hand, still at 3 years, half of the patients without any treatment do well. It means that it's not very clear if you should start the treatment with rituximab at the time of the diagnosis, and to be honest, we do not recommend it. It's more or less, it's not reimbursed. But our patient was a high tumor burden, and what options do we have? So the high tumor burden we usually treat with any kind of the chemotherapy in combination with rituximab. The most frequent regimen used is R-CHOP, and based on the PRIMA data, we use the rituximab maintenance with the aim to prolong progression-free survival and ultimately overall survival. The other very interesting option is to replace the R-CHOP with the R-bendamustine. And the last year published data from Matthias Rommel and co-workers showed that the R-bendamustine, at least in their hand, work better compared to the R-CHOP. But nevertheless, we decide the patients to treat with the R-CHOP. The patient received 6 cycles of R-CHOP and then 2 shots of the rituximab monotherapy. And after this treatment, we performed the final restaging, and the patient reached a partial remission. The patient, based on the PRIMA data, was put on the rituximab maintenance, and the patient received 1 infusion of the rituximab every 2 months, and it was scheduled for 2 years. Unfortunately, after 1.5 years, the patients came up with newly enlarged lymph nodes on their neck or supraclavicular area. And we perform restaging, and you can see that the patient has a lymph node involved above and below the diaphragm. So we diagnosed the relapse while the patient was on the rituximab maintenance, clinical stage 3. There was no elevation of LDH, very good performance status, normal hemoglobin level. So the FLIPI at that time, although the FLIPI was not validated for the relapse setting, but nevertheless there were only 2 factors. So the question was what we can do with this patient. This is a patient who were rituximab resistant by the definition, but the tumor burden was definitely low. We performed a rebiopsy, and it revealed that it's still follicular lymphoma, grade 1-2, and we discussed with the patients what we can do. So finally, we decided, and the patient agreed to go with the watch and wait policy again. And until from this time point, it means in the spring 2012 till now, it means within 2 years, there is very slow progression in the size of the lymph nodes, but the patient feels very well. She has no problems. She travels, she sports, so she is in very good condition, and she decides to continue with watch and wait policy. If we have to treat the patient at the time of the relapse on rituximab treatment, it's a really tricky situation, because it's a rituximab, it would be the rituximab resistance, and we can instill the chemotherapy, we can try another antibody, but it has been shown that the different anti-CD antibody has only limited impact on the relapse overall response rate, like ofatumumab. nowadays there are studies combining the new anti-CD20 antibody obinutuzumab plus bendamustine. We can definitely explore the targeted treatment like lenalidomide, which has been shown very active in a monotherapy settings or in a combination with rituximab or dexamethasone. For young patients who are really progressing, the autologous stem cell transplant and sometimes allogeneic stem cell transplant can be option. So what we can conclude and what should be take-home message from this slide? So the first one is that the initiation of treatment should be started only in symptomatic patients or the patients with high tumor burden. The second point is that the FLIPI itself is not sufficient for this decision. And the watch and wait policy is still a very useful approach in the rituximab era. And this policy, watch and wait approach, can be applied in the relapse setting and in this particular case in the relapse which occurred during the rituximab maintenance. Thank you.